So we'll move on to the third section of this session, which is a presentation by Fran Game, who is with us, who is going to describe another trial called the Leucopatch trial and other trials, evidence for the efficacy in hard-to-heal ulcers. Fran.
Thank you, and thank you for that kind introduction and for not saying what you said you were going to say about me earlier on. So I get the title of Leucopatch and other trials, and I am going to talk about the other trials which are unnamed. So here we are, we've got a nice pair of feet. Somebody gets diabetes, they get arterial disease, they get neuropathy, they get deformity, and then something happens. Something happens to precipitate something on their feet. It's usually trauma, hopefully not caused by an orthopedic surgeon, or a nice pair of footwear, although they're to be forgiven if they look like this. And unfortunately that leads to an ulcer, and that ulcer just sticks around for a very long time. And this is the problem, is how can we speed up that ulcer healing? And this is the area we're going to look at today. And these ulcers do stick around for a huge amount of time. William's going to talk about the National Diabetes Foot Audit, I hope, in the last session of the day. And these are some slightly out-of-date data now, but I couldn't be bothered to update my slide, showing that actually at 12 weeks, the proportion of patients who are alive and ulcer-free of those that are registered in the National Diabetes Foot Audit, and I'm sure William will say, if you want better quality data, then please upload your data. 34% alive and ulcer-free at 12 weeks and only half at 24 weeks. I mean, this is a huge cost to the health service of continuing to treat these patients over that time, not to mention the sheer misery to the patients and the risk of amputation. And a lot of this centres around chronic inflammation, and by being the third speaker, I'm allowed to wrap up what the others have said and tie in the mechanisms together before we get on to what I'm supposed to be talking about. I will get there eventually, I promise you. I'm just eating into my discussion time as being the only live speaker. I don't want to end up like poor Dr. Lee yesterday, who got a barrage of questions. So I'm going to continue to waffle for some time. But here you see chronic inflammation, those inflammatory cytokines, which then move on to proteases, MMPs, and the degradation of the matrix and growth factors. And you can see on this neuropathic ulcer, which hasn't been well offloaded, how that just bores a hole into the patient's foot through the clear degradation of the tissue. And this is an area, obviously, that all of these agents are trying to impact on. We saw the influence of topical oxygen on these inflammatory cytokines in Bob's talk first, and how that can feed into the reducing the impact of this pathway. And as another aside, I'm really eating into my discussion time here, aren't I, Chair? As another aside, I'm sure that Jerry and I would be more than happy to discuss the International Working Group guidelines on hyperbaric oxygen, perhaps over lunch, and defend our position. It could have been a humdinger of a debate, perhaps for the future. If Bob had been in the room, Bob and I are very good friends. I can almost see him leaning on the microphone going, Fran, 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 Fran. But we did have very good reasoning behind making that recommendation, and I look forward at some stage to defending that. Okay, moving on. And we've also heard of the influence of sucrose octasulfate on the proteases, and then we can look at whether we can boost those growth factors and try and prevent that tissue breakdown. And, you know, there are a huge number of dressings around, and they cost the NHS. Again, these are slightly old data. That means there's only, it's probably only worse. And this is all wound dressings in the UK, and this is just the prescribed dressings. This is not the cost of somebody putting them on and going and monitoring that patient. Massive, massive cost of dressings for all wounds in the UK. And here's the breakdown of some wound care products, the majority of which are not evidence-based. I just want you to focus on the light blue triangle there, if I can get up here, which is actually silver dressings. These are the number of prescriptions. If we actually look at the relative cost, it leaps up. So we can see that the cost of some quite common dressings actually overwhelm the number of dressings, and as I say, many of these are without evidence. So we're spending a huge amount of money on dressings and agents that actually have no evidence behind them. Now, absence of evidence is not evidence of absence of effect. Nevertheless, in a cash-limited society, and certainly if these were drugs and were bound by the same regulations, we would have more limited prescribing of them. Okay, so where is the evidence? Well, we've talked to you, you've probably seen this slide several times this meeting. There's a lot of evidence coming from the International Working Group. This was the last lot of guidelines. We've looked at some of the infection guidelines, the classification guidelines. The wound healing interventions are what we're going to talk about today, particularly a couple of wound healing interventions that were pulled out from this guideline. This was chaired by our chairman, Jerry, on this occasion. So any questions to him, please? This is the list of recommendations. You probably can't see that, those of you sitting by the open windows in the back. I know that because I sat there yesterday. Nevertheless, there are 11 recommendations, and most of these are we suggest you don't bother with this, or the quality of evidence is very poor, as we've heard, from several speakers today. So this was the sucrose octasulfate, which we suggested you could consider with weak recommendation based on moderate quality evidence. We're going to talk about the autologous leukocyte platelet fibrin patch next. Again, weak recommendation based on moderate quality evidence. And the third thing that I'm going to take up my time with is the other recommendation, which was placental derived products, which is a weak recommendation at the time based on low quality evidence. But this was, we took the cut off for these trials at about 2018, I think. Jerry will remind me. So I just want to update some of the work that's been done in this area since. Okay. Now, as a conflict of interest, I was the first author and the chief investigator on the Leucopatch paper, and many of the experts in the room doing that work were actually first authors and chief investigators on the other products. So we took a very rigorous view of evidence evaluation. We used the SIGN methodology checklist to grade the quality of the evidence, and we also, on this occasion, went through Williams' 21-point checklist, which goes through study design, study conduct, whether the outcomes of what we would expect from these populations, and study reporting. So we also graded all of our papers by that. And if one of our own papers was being discussed, or a paper that was done predominantly in our organisation, or the chief investigator lived down the road from us, then we stepped out of the room and weren't involved in the debate at all. So it was about as rigorous and unbiased as you can get, bearing in mind that the whole world is biased. So this paper has now been published, so I'm not going to go through too many details because it's all in there. It was published in 2018, not long after the sucrose octasulfate paper. So what is Leucopatch? It's now marketed as 3C patch. You can go and look at a stand upstairs. Free marketing, they're up there. A Leucopatch is made from 18 mils of patient blood. 18 mils gives you a 5 centimetre square patch of fibrin platelets and leukocytes. You can see the picture of somebody taking it out of the centrifuge there. We were quite interested in this when we first saw it. 2 pilot studies had suggested benefit without serious adverse effects, so we thought it was worth doing an appropriately powered trial. So we designed a multi-centre, multinational, observer-blind, randomised control parallel group trial. This involved 32 specialist diabetic foot centres in 3 countries, in UK, in Denmark and in Sweden, and I have the grey hairs to prove this. It was a longish trial for patients. We had a 4-week run-in. I'm showing you some of these details so you can see the comparison between other trials in this area. So the Explorer study with the sucrose octasulfate dressing had a 2-week run-in, as many of the others did. Certainly most US studies have a 2-week run-in of usual care. That's the FDA standard. 20 weeks of intervention, which was a weekly intervention, and then 6 weeks of follow-up. And our aim, you can read probably better than I can. So our inclusion criteria, again, just to highlight the similarities and differences. People with diabetes, ulcer on the foot, Our hard-to-heal ulcers meant that in that 4 weeks, with usual best standard care, including offloading where appropriate, that the cross-sectional area would decrease by less than 50% during the run-in period. So these were really hard-to-heal ulcers. We gave them a good 4 weeks, a good try. We were fairly pragmatic about the HbA1c control. The only reason why we went down to 50 square millimetres at randomisation was it's actually quite hard to cut that patch below that. We at baseline at randomisation they were non-infected, but if they otherwise would have got through running and screening, we could treat them then and we re-ran them. But there was only one ulcer per patient. We didn't re-randomise a patient if they got another ulcer. So one index ulcer, one patient. So all the ulcers are patients. ABPI between 0.5, we took these quite low, and 1.4. If it was greater than 1.4, then they had to have palpable pulses. And we did, I'll show you the baseline results. There was a smattering of greater than 1.4s, and obviously patients with capacity. So this is a consort diagram. We actually consented 595 participants and randomly assigned 269. The main reason for them not getting through that run-in period is that they healed too well, or they became too small by the time that they were randomised, which I think was a testament to the good care that we saw in our centres in these 3 countries. There's nothing surprising about these. They were the usual age, 82% male, majority had type 2 diabetes. Their HbA1cs were actually pretty good, I think, for my population anyway. Clearly, you know, my patients were at the upper end of that range. The majority of them had normal renal function, but we did allow them to go in up to an EGFR of above 20, but there weren't that many at the lower end of the range. These were the ABPIs, as you can see. We categorised them because of the difficulty with the greater than 1.4 scenario, but 17% of them were greater than 1.4, and the majority of them were neuropathic. The mean area of the ulcer at baseline was 240.8 millimetres squared, very precise. And the majority of them were superficial. We did take a couple down to bone if they were not infected. And the majority were on the forefoot. So moving swiftly to the end, the blinded assessment of healing within 20 weeks. So the assessment of healing was done by somebody who was blind to the patient status, so by a clinician. And we had a fixed definition of healing, and that was full epithelialization without drainage, and it had to be maintained for 2 weeks. And so in the intention to treat analysis, and this is exactly what Bob has said, we should always look at the intention to treat analysis, 22% healing at 20 weeks in the standard care versus 34%, and that was statistically significant. You'll see that the healing rates in the usual care arm were lower than you saw in other studies, and I think that relates to our run-in, which was much more rigorous, and we took more patients out in that stage. So this was a really hard to heal population. When we adjusted for baseline wound area, that odds ratio increased, and the protocol is there for anybody who's interested. Just to nail it, these were the time to healing, which you can see a clear difference in the time to healing, and that was statistically significant as well. So we have discussed sucrose octasulfate, we've discussed leukocyte, platelet and fibrin patch. This is currently with NICE for review for health economic analysis in the UK now. And the third thing I want to talk about is placental derived products. So most of these are from amniotic membrane. They're derived from donated human placentas. These are usually women who donate their tissues at the time of caesarean section, and certainly in the UK these are all screened, rigorously screened. I always think the risk is very low because if a woman is prepared to be screened for every infectious disease that might be transmitted through tissue, then the likelihood is they're a very low population to start with. They come in 2 forms, either dehydrated or cryo-frozen, essentially, which means that these frozen ones have cells in them. The difficulty with the frozen ones, as you can imagine, you get this out of the deep freeze, you carefully defrost it in your clinic, and then the ambulance doesn't come with your patient. So, or the patient turns up and is not willing to wait for the flipping thing to be dehydrated, so defrosted. So they're difficult to handle. In fact, there's only one product in the UK at present which is dehydrated, which is being marketed, but I'm not aware of any massive use in the UK at the moment. However, in the USA, these products are much more prolific. And if you've got an evening where you fancy, where you're a little bit of insomnia and you want it curing, then this technical brief I can recommend to you. It's bang up to date. It's a really good quality technical brief which really looks at the studies available in some detail. It is actually all skin substitutes, including placental derived products, and it looks at DFUs, VLUs and pressure ulcers for those of you interested in other wound healing systematic reviews. And these are the products that are available in the USA. These are the frozen ones because they contain cells, and these are the dehydrated ones. So, and we will have never heard of the majority of these. Massive proliferation in this area and marketing in the USA. And these are the randomized controlled trials of diabetic foot ulcers that were included in that technology appraisal. Fortunately, I can't see the timer. That's all right, I've got loads of time. Spin it out a bit more, I don't want questions. These are the RCTs which I've pulled out from that document of diabetic foot ulcers. Now, there's a very well-known statistician who those of us who have submitted papers to a certain well-known diabetes journal will have heard previously that in a paper where there's more analyses than patients, it's dodgy. Where you've got more products than trials, you've got a problem. And this says there's a huge, and I only say this because it's coming our way, there's a huge proliferation of products and very few of them have actually got good quality trial evidence behind them. But there are a number. Now, the risk, you can see the odds ratios there, the risks of bias are actually the risk of bias that was assessed by the people doing this analysis. They're not necessarily the risk of bias that I would attribute to these studies, but nevertheless, I've just taken them verbatim. And you can see the odds ratios of healing, range between 1.2 and 6 or 11, I think. Time to healing, they followed up for 6 weeks, mainly 12 weeks according to FDA criteria. You will also note that the biggest studies, they're the ones done by Bill Tettelbach, 155, 120 numbers. The bigger the study and the lower the risk of bias, so the better quality study, the odds ratios of healing are lower. And we see that a lot. The more biased the study, the more emphasised the result is. So that doesn't surprise me at all, and also tells me that those studies probably were good quality. Now, the reasons that I say I would quibble with some of those risks of bias is that none of these may have been observer blind, the outcome were blind, but none of these were blinded. The patients and the caregivers weren't blinded, which was actually the same in the Leucopatch study. We genuinely felt we couldn't blind the patients because we were taking, on occasions, 36 mils of blood and putting it in a centrifuge. Having said that, we didn't actually try. We just sat around and said, we don't think we can blind it because of the volume of blood, the difficulty of taking blood. Do we take 36 mils of blood and risk anemia and then not put it through the centrifuge? We went round and round, but we can be criticised for the fact that we didn't blind the patient and the caregiver in Leucopatch. And it's the same here. Now, the standard in that sign guideline checklist that I showed you was you get a tick if the patients and the caregivers are blinded, if it is possible to blind the study. So there's a bit of subjectivity in there. So if you say, actually, I don't think I could blind the study, you would probably get a tick in the box and you'd get a low risk of bias here. So the question is, did any of these people actually try to blind the patients as to what they got on their foot? And they would say, you can't blind, we haven't got placebo amniotic membrane. There are other ways of doing it. And whenever anybody says to me, you can't do it, I usually think, oh, really? Let me try. My team will know that. And that look on my face, well, I think there's got to be a better way of doing this, and they're all quaking in their boots about what I'm going to come up with next. So what we came up with next was a pilot study of a new amniotic membrane product, which is actually produced in the UK. It's actually produced in Nottingham. It's a spin out of Nottingham University. It's been widely used in ophthalmology, hence the New Vision logo there. But it's never been used in diabetic foot ulcer wound healing. But it is quite widely used in ophthalmology. And so we did a pilot study, a proof of concept, to look at, see if there was any good outcome data we could use to power a proper trial in the future. And one of the things I was really keen to do was to say, can we blind? Can we blind the patients and caregivers? Because actually this would give us a much better quality study at the end of it. And we would really know that, that we can produce a low risk of bias study. So we consented 34 patients and randomised 31 in 2 centres in the UK to amniotic membrane or standard of care in each group. And we blinded them. I'll tell you how we blinded them at the end. This is a pilot study. It wasn't powered for outcome. Nevertheless, we were encouraged by the direction of the change, and we're currently writing the protocol for a full trial based on the sample size calculations that we can take from here. There was a difference at 12 weeks in wound area, and my statistician will kill me if I tell you that that was statistically significant, because it was a pilot, it wasn't powered for that, but nevertheless the wound area reduction from baseline was statistically significant. But you didn't hear me say that because I'm a purist, as he is. And this are the blinding results. So at the end of the 12 weeks, or if they'd healed, we asked the patients if they knew which arm they were in. About half of them, you can see at the bottom here, about half of them said they genuinely didn't know what arm they were in. But the other half did actually try and guess which arm they were in. So this is the actual arm they were in, and this is what they guessed. So of the 5 that said that they thought they knew what arm they were in, 5 of them said that were in the amniotic membrane arm said that they thought they were in the amniotic membrane arm. But equally, 5 patients who were actually in standard of care thought they were in the amniotic membrane arm. So we're fairly confident, there is a fancy statistic that you can apply to this, but we're fairly confident that patients were actually truly blinded to what intervention they were having. Interestingly, these 10 patients, almost the most common reason why they thought they were in the intervention, and half of them weren't, is that their ulcers healed quicker than they thought they would. So this is what we call the optimistic guess. It's doing really well, so I must have had the intervention. And there's some interesting psychology behind then how they behave and how they go on to heal, which is why patient blinding is so important. So what we did here was, this is human tissue. And human tissue has to be tracked. So it comes in a little packet with lots of digits on, which we have to document, because even though the risk to the patients is very low, it is human tissue, we do have to track it. And so we had dummy packaging made up with dummy numbers. And in that packaging was nothing. But we could tell the difference, but to all intents and purposes, to the patients, it was dummy packaging. We documented the numbers. Then we draped the foot. The patient couldn't see. And then we put the podiatrist through some acting training to open the packet, take it out with their 2 forceps, put it on the wound, accidentally drop it and say, "Ooh, that would have been expensive." And then, and then it was ready. So how we're going to do that in 32 centres in 3 countries, I don't know. But anyway, it worked in our 2 centres in Nottingham and Derby. So we're fairly confident that we can. It'd be interesting to see whether those odds ratios continue if we manage to blind both arms. So I'll tell you about that in a future meeting. Not the next one. We're not going to do this in a year. Okay, so we've talked about these 3 areas. Time's up. carry on talking, Fran, you don't want the questions. We talked about these three areas. You see that even in those that are positive, the quality of the evidence is low. I think, when we take our cut-off, we're currently working on the next iteration of this. Then I think we've got an awful lot more studies to go on, and some of these recommendations will go from low quality evidence to moderate or moderate to high, because we've got so much more data and so much better quality studies to go on. So thank you very much for your attention.